Total robotic approach for renal cell carcinoma with level 4 IVC thrombus. This is a 71-year-old female with a history of weight loss. CT scan demonstrated a 12 cm left renal mass with a thrombus extending into the inferior vena cava all the way up to the atriocaval junction. The patient was initially placed in left lateral position for left nephrectomy and dissection of the left lobe of the liver. A huge mass displacing the colon medially was identified. The ureterogonadal complex was elevated and the renal vein was dissected meticulously. Subsequently, the lumbar veins were clipped and renal artery was identified. The renal artery was divided in between two V clips. The renal vein bearing the tumor thrombus was stapled. Further proceeding with the dissection, it was noticed that the tail of pancreas was infiltrated with the tumor. The left lobe of liver was mobilized by dividing the left triangular ligament and the gastrohepatic ligament. The IVC was fully exposed on the left side. The patient position was changed to the right up and the stump of the left renal vein near the IVC was lifted up. The right renal artery was dissected in the interaortocaval region and the IVC on the posterior aspect was completely mobilized. The right renal vein was also isolated and looped. Subsequently, the right lobe of the liver was mobilized. For better exposure, the short hepatic veins were divided. Phrenic veins encountered over the diaphragm were also divided in between. Patient was placed in supine reverse Trendelenburg position with 10° up. The falciform ligament was divided to get exposure to the IVC. IVC was circumferentially mobilized in the suprahepatic area. A 6 French infiltrating tube was looped around the IVC. To further increase the exposure of the suprahepatic IVC, the central tendon of the diaphragm was carefully divided. This gave us access to the IVC at the atriocaval junction. In instances where the thrombus is extending into the atrium, the pericardium can be incised, exposing the right atrium and thereby allowing the access to loop the IVC at the atriocaval junction. Once the liver was thoroughly mobilized, the porta hepatis was controlled using a Foley catheter. Sequential clamping of the inferior vena cava was performed, commencing from the inferior end, then the right renal artery and the right renal vein was also controlled. The loop over the porta hepatis was tightened to restrict the outflow from the liver. At this juncture, a transesophageal echo was performed to assess the extent of the thrombus, coupled with the intraoperative drop-down Doppler probe. This enabled us to squeeze the thrombus from the atrium into the suprahepatic inferior vena cava. A bulldog clamp was applied to control the suprahepatic vena cava. The IVC was opened and the thrombus was extracted with the excision of the stapler line of the left renal vein stump. Then the control was obtained in the intrahepatic IVC and the thrombus was placed in an endo bag. The suprahepatic clamp was released, followed by the porta hepatis, thereby reinstating the flow to the liver. Simultaneously performed transesophageal echo confirmed the complete removal of the thrombus. The IVC was thoroughly flushed with heparinase saline and the suturing was commenced from the inferior end. Another suture was started from the superior end and both ends were tied together in the middle. Once the suturing was completed, the clamps were sequentially released, starting from the right renal vein, the right renal artery, the intrarenal IVC, and the infrahepatic IVC. The diaphragmatic incision was reapproximated by using a 2-0 barb suture.